As we're getting started here, good afternoon, everybody. Welcome to the final session of the Rover second annual program for medical students. This will be a fantastic session on GU cancers. Again, we have a phenomenal panel. I'd like to introduce you to Doctors Sophia Cameron, Rahul Tendulkar, and Bob Dess. They're coming to you respectively from Mass General, Cleveland Clinic, and the University of Michigan. If we can go forward to the next slide. One back. If you could take a minute and just introduce yourselves and let us know what made you choose radiation oncology or something that excites you about your job on a daily basis. If you want to go ahead, Dr. Cameron.
Sure. So welcome, everyone, and thank you for the invitation. I'm very excited to be here. So as you know, my name is Sophia, and I am a genitourinary radiation oncologist at MGH in Boston. What brought me to radiation oncology? So I'm a nerd at heart, and I was actually really interested in physics. I know that sounds strange, math and all those things, but I came from an engineering background, and I actually was really attracted initially to radiology. I loved the technology. I loved, imaging and the physics behind it. But I really also loved oncology patients. And so when I told somebody this, they said during medical school, they said I should look into radiation oncology, and I did, and haven't looked back since. So it's been a lot of fun. And on a day-to-day basis, what I love about my job is that every day is so different. And then, especially with genitourinary cancers, I get to use all sorts of modalities to treat, and I think that is really special.
Great, thanks. Dr. Tendulkar? Oh, you're muted.
Sorry, thank you. Thank you again for the invitation to be here. I'm excited to meet with the group. Like Dr. Cameron, I also have an engineering background. I studied mechanical engineering at the University of Michigan, and during medical school, initially thought I would do something along the lines of orthopedic surgery or EP cardiology, and realized those weren't great fits. And I didn't discover radiation oncology till towards the end of my third year of medical school. So, never really had a chance to do much research into the field. But after a brief exposure, found this to be the best fit and have loved it ever since. So very excited to be here.
Chris, your screen is being shared. Go ahead, Dr. Dess.
Bob Dess, nice to meet you, and thanks for the invitation. So I spent about a decade in a different career in finance before I switched careers into medicine. And I went to the University of Chicago, and when I met, I sort of you look back through retrospective scope and try to figure out how you ended up in radiation oncology. And I think it's a combination of, I really liked that radiation allowed for us to have time to speak to patients. I liked that we had a very unique modality that very few people know anything about, and that's both a blessing and a curse. And I think it's much more of a blessing than it is a curse that we get to explain to many other people how we can help them. And it's also nice to be masters of your own universe. You really can do it and other people cannot. And so that really, I think, was a gravitational pull. And then the hook that caught me as I met, Stan Liao really was an influential member to me, who sort of viewed my success as his own. And that's really why when they reached out to me to do this, I said yes in a heartbeat. And I think that our obligation is to help people like you who show up here on a Friday afternoon, or I guess midday, depending on where you are in the country, to help make you excited for our field. And then the sub push is for, if you ever are in our field, genitourinary oncology is fantastic, because like Dr. Cameron said, it is a very diverse set of populations with a very diverse set of outcome expectations, with a lot of different ways we can help people. And so whereas certain disease sites, there's one thing you do and they know what you're doing, for us, there's a lot of words, and we talk through them and help them figure out what the right thing is to do. So thanks for the invitation.
Wow, that's an exciting intro. I'm dying to hear all the options that we have now. Okay, well, we also have a fantastic moderator this afternoon. We have Dr. Daig from Oregon Health and Science University. He's a PGY5 there. Chris, would you like to introduce yourself?
Yeah, thanks everybody for coming today. I missed the last few answers because my audio totally cut out. So sorry if I repeat. But I caught the tail end of Dr. Des mentioning that it's a small field, and I think that really resonates with me and the advantages of that, because we're really here to help. And when you reach out to any radiation oncologists across the country, people are really searching for people who are enthusiastic about the field, who care about the future of the field. And, it's part of the reason why we developed this program in general. So, please don't hesitate to reach out to any of us. We're here to help and excited to help. And we love what we do. We're excited about the future of the field. So we will get going with our first case if everyone's ready.
Can I just remind people that if you have questions or thoughts during this, just go ahead and put them in the chat. Just make sure your setting is to everyone, not just to hosts and panelists. Thank you.
Awesome. So our first case, this is a 65-year-old male. He initially presented to his PCP with nocturia and frequency. He started on tamsulosin, and him and his PCP talked about the pluses and minuses of PSA screening. And so I'll first ask Dr. Cameron if you have a perspective, what your thoughts are on PSA screening.
Sure. So PSA is made by the prostate. It's prostate-specific antigen. It's made by the normal healthy prostate, and it's also made by prostate cancer. So it serves as a good potential biomarker for prostate cancer. There are many pros and cons to PSA screening, and that actually kind of resonates with how PSA screening has risen and fallen over the years with regards to recommendations. It's been very controversial, but I think one of the pros is that, we do have a blood test, a simple blood test to potentially detect prostate cancer. And I'll kind of get into the potentially detect. And I'd love for the other, my co-panelists to jump in at any time if they have anything else to add. I'm sure they have many thoughts, but there are cons to it too, because it's made by both the healthy normal prostate and as well as prostate cancer. So it's actually an excellent biomarker to follow after treatment for prostate cancer. It's a really, really, really solid biomarker, and we're very lucky to have it. However, in the upfront setting, it can be a little bit of a muddled picture because there are patients that can have elevated PSA for a multitude of reasons and actually have no evidence of prostate cancer at all. So it makes it really difficult to kind of tease out what a PSA may mean. And I think that has led to the controversy with PSA screening, and which is why I think it was introduced that, it's a discussion with your PCP or whoever is screening, because there are a lot of controversies with it. There are things that can make PSA elevated, falsely elevated, bike riding, ejaculation, if you've had a recent rectal exam, if you have an infection. So that can falsely make it very high. But again, as I emphasized, that person may not have any evidence of prostate cancer. And so they may be subjected to biopsies or treatments even, and not actually have any evidence of prostate cancer. So we have to be very careful with PSA screening in the upfront setting. But I think we're very lucky to have it because it's a phenomenal biomarker after initial treatment for prostate cancer, and we can really follow it without being very invasive because it's a blood test. And maybe I'll pass it along to my co-panelists to get their thoughts as well.
Dr. Des, that was a phenomenal overview, Dr. Cameron. Dr. Dusty, I'll pass it on to you if you have anything.
Yeah, I agree. I mean, it's a giant topic. I mean, we could have 3 hours of discussions on this. I think Dr. Cameron did a great job. I mean, it's the layers of this question is what are the pros and cons of screening, and then what are the pros and cons of what you do after you have an elevated PSA. And so I think if you unpack it a little bit, what we have done as an oncology community in the past, over the past 20 to 30 years, is probably arguably maybe not a net benefit for screening, or at least in a lot of men, in terms of over treatment. But I think what we're trying to do now is more intelligently use combinations of screening, MRI, other biomarkers to increase the chances of detecting cancers that are worth treating and decrease the chances of detecting cancers that aren't worth treating. And even if we detect those cancers that aren't worth treating, how do we do appropriate surveillance, and how do we alleviate the potential anxiety of that diagnosis? And I think I'll even put you into this camp, Dr. Tendulkar, is that I think our generation has been trained, I think, much more comfortably in concepts of active surveillance, and not always do we have to act on an invasive treatment right away. And so from the perspective of the radiation oncologist, I think our roles are as much, the screening may have been done already. And so how do we appropriately act in the patient's best interest for their quality and quantity of life?
Yes, thank you for including me in your younger generation category. But yeah, I totally agree. I think from just a teaching standpoint, the concept of overdiagnosis is basically finding a cancer that was not going to be lethal to a patient, and is not, and treatment of which is not going to, expand their overall survival horizon, and obviously a lot of side effects associated with treatment that we'll talk about can be a detriment in patients' quality of life. So really trying to find patients who would benefit the most from treatment is, I think, the kind of the holy grail of what we're trying to get after with screening.
Great discussion. So PSA was done after shared decision making, found to be 8 nanograms per milliliter. The PCP referred the patient to urology for this high readout for a transrectal ultrasound guided biopsy. So the next question, I'll go back to Dr. Cameron. What is a TRUST biopsy, and what is Gleason score?
Okay, sure. So TRUST biopsy is a transrectal ultrasound biopsy, guided biopsy. Basically, if you can look at the schematic on the left-hand side, you can see the rectum is kind of written out there, but basically they would use an ultrasound to insert into the rectum, and you can get a great view of the posterior part, especially of the prostate. You can get a view of the prostate gland, and they take a needle and that's attached to the ultrasound and actually take pieces of the prostate gland. That a number of pieces of the prostate has expanded over time. I think in general that they say the standard number of biopsies is 12 cores. So 12 different parts of the prostate are, 12 pieces are taken from different parts of the prostate, and you can actually see on the right-hand side, there's that schematic right and left of the prostate, and kind of they go to the different parts, like the base, the apex, and the middle, and the left and right. And so that's generally the standard when using the TRUST guided biopsy. And then with regards to Gleason scores, so that's what they look at underneath the microscope. That's what our pathologists look at, and that's been developed by Dr. Gleason a long time ago. And basically, they look at the shape and the architecture of the cells underneath the microscope, and they give it a grading based on how abnormal those cells look. And the score goes from, it starts at like 1 and 2, but really we're looking at the 3 and the 4, 5, 6, 7, 8, 9. It's based on how much it adds. So you add up the 2 scores. So Gleason 3 plus 4, as you can see in this gentleman, total Gleason score is 7. And they're actually moving away from this because this is actually quite confusing. So we're moving to grade groups of between 1 through 5 because these Gleason scores are really confusing for patients in terms of like how to add things up and what means what. And so we're actually moving away from this. So that's just based on the pathology underneath the microscope.
Great, thank you. So his biopsy did reveal a Gleason score of 3+4 and 2 of 12 cores, as you see on the right side. And so the first poll, which Nav will pull up, is how do we risk? Actually, we'll skip this one. I didn't update the updated question. That's okay. But I will pass it to Dr. Tindokar to just comment on how do we risk stratify patients.
Yeah. So historically, there have been 3 components to risk stratification, which is primarily based on the PSA at the time of diagnosis, the Gleason score that's found at the biopsy, and then the DRE findings. So a digital rectal exam is done. And on the previous picture, you saw a nice schematic of the prostate. The peripheral zone is the part that you can palpate on a digital rectal exam, and that's actually the part of the prostate that you can see right there that comprises the vast majority of prostate cancer. So it tends to be fairly useful, especially in the pre-PSA era or in countries where PSA screening is not readily utilized. The digital rectal exam still plays an important component. I think in the modern era, in an environment where screening is being done, we're less commonly finding palpable disease and more commonly finding prostate cancer that's been diagnosed based on an elevated PSA. So to go back to that question, we use those 3 factors to risk stratify patients, and this scale essentially goes from low risk to intermediate risk to high risk. In each of those groups is kind of divided up into 2 categories. So there's basically six categories within the spectrum of localized prostate cancer. So patients who have a very, you can see there, if they have a T3A disease, which is palpable disease outside of the prostate, or Gleason score of 8 to 10, which is a high-grade cancer, or a PSA above 20, those fall into the high-risk category. And then low-risk prostate cancer usually is has to have either non-palpable disease or a small nodule, or a Gleason score of 6, and a Gleason score of no higher than 6, and a PSA no higher than 10. So if you meet all of those criteria, then you fall into a low risk category. And then if you have one of the intermediate risk factors listed there, then you fall into the intermediate risk category. And so this roughly dictates the prognosis as well as how aggressive our treatments have to be for these patients.
Great, thank you. Dr. Dess, would you order any additional workup?
No. I mean, largely there's some debate of, but given a T1C low volume 3+4 disease, there isn't currently a role for imaging beyond for staging purposes. We tend here, if they haven't already received one, to get a diagnostic MRI. That's usually done as part of their biopsy purposes, but if it hasn't been done, it can help for underdiagnosed or undersampled disease, particularly in large prostate glands, because as Dr. Cameron showed, there's they're biopsying systematically, but not particularly targeting an area in the prostate. And it particularly can help with if somebody has poor urinary function. You may understand that they have a large transition zone or a large benign prostatic hypertrophy that may affect our treatment options. And so the diagnostic workup from the perspective of helping with treatment options or understanding the extent of the disease, MRI would help, but we don't tend to worry about the occult metastatic disease in these patients. Anybody else do anything else in these lower volume Gleason 3+4 disease? That we're learning from each other as much as we're learning from you guys. So I'm happy to hear the experts tell me if they do anything different.
No, I would agree with what you said, Dr. Dess. I mean, in general, we typically obtain a prostate MRI, but it's not for, staging purposes in terms of looking for metastatic disease or anything like that. It's really about looking at the state of their prostate and the shape, and if there's any nodules or, I don't know if we're going to get into PIRADS and everything like that, but and it helps with surgical planning. And then especially if a patient is interested in brachytherapy, it helps me with that type of planning.
And I think it's, the patients with low risk and favorable intermediate risk, which I think this patient qualifies, they have such a low risk of metastatic disease at the time of diagnosis that doing a routine staging workup is largely unnecessary. So really, we reserve it for the high risk patients otherwise, and that's standardly a CT of the abdomen, pelvis, and a bone scan.
And for some of the medical students, I mean, this isn't just sort of preferences. These are things that large statewide quality initiatives have tried to optimize, at least in Michigan and elsewhere, of unnecessary testing, of unnecessary radiation exposure, although we're about to give more radiation to this patient, but basically in a cost-conscious, high-value, delivery of care, unnecessary bone scans and CT scans in the favorable intermediate risk population, or low risk for sure, has been a goal of ours, to basically maximize value.
Awesome. So another poll question: what is not considered a curative treatment option for prostate cancer?
Maybe while that's coming in, there's a question in the Q&A box about the use of urinary exosome analyses.
There are a lot of non-commercial exploration in terms of helping with the utility of diagnosis, is what I'm aware of mostly. Michigan has some of those too. I don't tend to order any urinary exome analysis in my consideration of treatment.
Yeah, I would agree with that. There's a lot of research being done and it's being explored, but it hasn't been it hasn't moved into the standard of care or the point of care or anything like that. But it's really, really interesting things that are going on.
The brachytherapists are going to be so sad, myself included here, with these answers.
Oh gosh,
Oh,
yeah, that's very
Rough
sad.
crowd.
So will the cryotherapists, for the record.
yeah.
Um,
For the medical students, it's okay. There's no criticism of answers. It's more, it's a knowledge. It's our responsibility to share this knowledge rather than your responsibility to know the answer.
yeah. So Dr. Cameron, what are his treatment options? We didn't invite the cryotherapists to talk.
Yeah, so I think when discussing with these patients, I kind of like to frame it that there's a couple different intersections that you first decide. So I think the first decision is, do you want to talk about treatment, or would you consider active surveillance? So that's kind of like a management decision. And then if you do go down the road of treatment, given let's assume he's otherwise really, really healthy and everything's great, he would be a candidate for surgery, which is typically radical prostatectomy. It could be robotic, it could be open, it could be laparoscopic. There's lots of options there. And then for radiation options, there's external beam radiation therapy, and that can be performed with either photons or protons. And then there's brachytherapy, both LDR seeds or HDR, which is catheter. I like to call it as catheters or needle brachytherapy, temporary. And then there's stereotactic SBRT, stereotactic body radiation therapy, that's being explored, and it's definitely up and coming. I think that's everything. And I would not consider androgen deprivation therapy as a curative treatment option to consider for this patient.
Great. So after a discussion with the patient and multiple providers, the patient decides to proceed with radiation. So Dr. Tindokar, what treatment techniques would you consider?
So intermediate risk prostate cancer is probably the one situation where almost any modality is appropriate. And as Dr. Cameron mentioned, there's two ways of doing brachytherapy. There's low dose rate, which is typically a permanent implant where you place seeds directly into the prostate, and then they stay there forever, and they emit a low dose of radiation over time. And then the HDR is the high dose rate brachytherapy, where we do a temporary implant, and the patient's prostate is exposed to high kind of doses of radiation in a short period of time. typically two fractions now is typically done. In this case, the advantage of the high dose brachytherapy, there's no permanent radioactivity within that remains within the patient. So I think either of those approaches of brachytherapy are fine. With regard to external beam radiation, there's photon-based, which is X-ray based radiation therapy. There's proton-based radiation therapy. Within the realm of X-rays, there's IMRT, which is intensity modulated radiation therapy of different schedules, and then SBRT, which is giving a high dose of radiation in a relatively short period of time, typically 5 treatments. So nowadays, I think SBRT is becoming much more popular among patients because you get the external treatment done in a much more convenient schedule compared to the typical fractionated radiation where you're giving a low dose over several weeks of treatment. So I would say most patients that I would see would select either brachytherapy. At our institution, we do low dose rate, which is a seed implant, which is a one-time procedure, and then SBRT. I would say those are probably the 2 most common techniques with regard to radiation that we utilize.
Great. Dr. Dess, when do you think about utilizing ADT or androgen deprivation therapy, and what is it exactly?
So I would not recommend hormonal therapy in this case. I think what hormone therapy does is, or there are multiple ways, it's a generic term or an umbrella term that is used interchangeably for drugs that work in different ways. And so the primary way is to trick the brain into not producing testosterone, or you can block the receptor of the testosterone with the prostate cancer cell. And we have spent probably $200 million and 30 years of studying in radiation oncology in the prostate world to understand what to use, when to use it, how long to use it, when to start it. There are questions that have good answers, and there are questions that have less good answers. But what we're, maybe I'm giving a little preview of the talk that I'm going to do at Astro, but what it seems to be is that hormonal therapy actually tends to work equally well across the risk spectrum. Even with low risk disease, it decreases the chance of the PSA coming back. But if you have a cancer that isn't going to spread or has incredibly rare chances of spreading, you don't get much bang for the buck. And so our goal and our forward research in our field has been to best understand which patients have a risk of a cancer spreading and which ones don't. And so that distinction right now tends to be for splitting intermediate risk in half, plus or minus. And for men who have unfavorable or high risk disease, we tend to offer hormonal therapy in general, and are cautious in men who have a pre-existing heart attack or cardiac disease or are elderly and may not see the biggest benefit for their hormone therapy. But this man, there are probably a few things that the 3 of us don't agree on. I think this might be an area that we would be in solid agreement that hormonal therapy would not be indicated in his case.
All right. So here is a simulation CT. If it plays, there we go. And this is the patient's treatment plan. So the patient was treated with hypofractionated radiation into 70 gray and 28 fractions without hormone deprivation. You can see the high dose is the red color, and yellow is intermediate dose, green is lower dose, and blue is kind of low dose path. So Dr. Cameron, what are the long-term risks of prostate radiation?
Sure. Sure. So I actually just saw a nice schematic, I think the other day that Astra made online that had a really cool like bubble diagram of like long-term risks. And anyway, I was just thinking about that in my head. But I think so. The main thing that will happen is that we treat the whole prostate, and the function of the prostate is to make ejaculate fluid. So the patient will lose ejaculate fluid over time, and that's also what happens after surgery because they remove the prostate gland. So patients will experience what we call a dry orgasm. They still have the feeling and the sensation, but it just changes. It's a little different. That's how patients describe it. It just becomes a little bit different. And then, there's an effect on erectile function for patients that they must be aware of. So the nerves and the vessels that contribute to erectile function run right along the prostate gland, and they do receive radiation therapy. Oh, there you go. Yeah, I thought this was a really neat long-term, like looking at the long-term. So more likely is on the left-hand side, less likely is on the right-hand side. So erectile dysfunction does occur over time. What we've learned is that those nerves and vessels basically are age faster. We know that natural aging contributes to a decline in erectile function in men as they age, but radiation appears to accelerate that decline. And of course, it's very individualistic. It really depends on how their erectile function is up front before starting treatment, what are the comorbidities they have, obesity. There's a lot of different things that go into this, but we do need to let them know that that's something that they need to be aware of. Of course, if they start noticing a decline, we can have medications on board, things like that. As you can see listed there, you can have some late urinary frequency urgency. So sometimes patients will describe that the urination has changed just a little bit, even in the months after the radiation therapy is done. Same with the rectal urgency. And loose stools diarrhea is less common, especially after radiation therapy is done, but they may complain of that, especially in like the first year or two after treatment. And then less likely, as you can see on the other bubbles kind of going away from the more likely is the long-term rectal bleeding, blood in the urine, and then really rare is a urethral stricture. So rectal bleeding and blood in the urine would be something that would be more common in patients that are on long-term anticoagulation for any other medical reason. So that's definitely something to keep in mind. But they're generally less likely. And then one thing that's not listed, but it's very, very rare and something to think about like in really, really young patients, but not so much for this gentleman, is a secondary malignancy caused by the radiation therapy. But again, that's quite rare.
Great, thank you. And for the record, there are these brochures actually in other disease sites, which are really helpful for patients. So moving on, Dr. Tendulkar, what can you tell us a little bit about LDR brachytherapy and HDR and its role?
Yeah, so absolutely. So yeah, I think I touched a little bit about the differences between them. So LDR is the low dose rate. And so this is a nice example of a patient who's had radioactive seeds placed into the prostate. These are typically done with transrectal ultrasound guidance. The way we do it at our institution is jointly with the urologist. So it's a nice opportunity for collaboration. The urologist kind of drives the ultrasound, and we place the seeds into the prostate, and we kind of create a template using sophisticated computer programs to figure out where exactly the seeds should go into the gland to cover the whole prostate with the adequate dose of radiation, while not overdosing some of the important structures in that area, namely the bladder, the urethra, and the rectum. And so once we determine the optimal distribution of seeds throughout the gland, then we kind of use a template. And I like to joke, it's kind of like playing Battleship. You're trying to get the needle, into the A1, A2, A3 slots, so you get a nice sort of distribution of seeds throughout, throughout the gland. And kind of using one needle at a time, you can deploy a handful of seeds throughout the gland. So it's a procedure that's typically done in the outpatient setting. And again, with the low dose rate, they go home the same day, which is really nice. So compared to external radiation, where they require multiple trips, and compared to surgery, which usually involves a hospital stay, this is a nice alternative to those. So we spend a lot of time, all of us who see prostate cancer patients spend a lot of time primarily talking about the differences in logistics and side effects, because the cure rate for somebody with a low risk or favorable intermediate risk prostate cancer is so high with all of these options. We really try to focus on quality of life differences between them.
All right, thank you.
I'm also happy to chime in for a minute. I do high dose brachytherapy if that helps.
Yeah, no, absolutely.
The principles are the same. You're using an ultrasound to guide the placement. Like Dr. Cameron said, you're placing catheters rather than dropping off seeds. And those catheters or those straws are the conduit to have a high dose rate activity seed go and sit into the prostate in each one of those catheters for a computer determined amount of time. And you can imagine those dwells are like lights or radiation bubbles that sort of grow to fill in all of the radiation dose to the prostate. And as with some things in life, we have a world's expert in LDR here and Bill McLaughlin. And so I just did the HDR side of things. And there are pros and cons to both in terms of logistics and side effects. And I think, I don't want to speak for the two of you, but what I like about here, and I know both of you have at your institution, what's fun about training, what's fun about where we work is we do get to talk about multiple options and sort of provide a menu of options that the same person, the same age with the same disease characteristics may choose 3 or 4 different options that are all okay for them. And it's, I like this disease site because I'm okay with helping them choose that uncertainty and sort of navigate that process. But you talk to men, not everybody wants to undergo anesthesia. Not everybody wants, to have needles in their perineum, but there are men that are very much gravitated to the precise nature of placing needles and the very conformal treatment plan. What we mean by that is the radiation starting from the inside out and really not having to go through many of those other tissues. Or they like the logistics of the convenience of being done, or they're, honestly, they talk to their friend Joe, and Joe had that and had a great experience, and Joe tells them to do that. There's a lot of nuances, I think, to the decision making, and it's fun as a trainee, as a student, to sort of have a broad experience to a lot of different modalities to find out that, one size doesn't fit all.
Awesome. And Dr. Cameron, when do you think about using SBRT?
This is a great question. So SBRT was explained a little bit earlier, but just as a refresher, this is just stereotactic body radiation therapy, and it refers to when we treat a gland or a cancer with a high dose and a short duration. So typically it's 5 treatments or less. And this has been explored and it's becoming very popular amongst the radiation oncology community. And I think it's probably going to become more popular as more time goes on and people become more comfortable with it and more data comes out. So basically, obviously, it's very attractive for patients because, traditionally we would say, oh, okay, it's between 20 and 28 treatments every day, Monday through Friday. And they're thinking, oh my goodness, how am I going to, get into XYZ every single day? Because it's a little bit of a nuisance. And so SBRT 5 treatments, that's definitely something that's very attractive, especially, if maybe patients aren't, that's something that actually patients are attracted. One reason why patients are attracted to something like brachytherapy is because it's kind of like either a 1 or done or 2 and done, treatment. And they like that. They only have to go to the hospital like kind of once or twice or, not that many times. But if they're afraid of needles or they just don't want any type of surgical anything, then SBRT is very attractive. So, basically the principle is that, we get to a very high dose and we're just compressing it and just delivering a high dose per day. And biologically it's equivalent, and we'll not go into that because that's, beyond the scope, and that's like a whole nother talk and everything like that. So, but anyway, we've learned with our equipment, we've gotten so great at with our equipment and our imaging and our guidance that we can safely deliver such a high dose to a very targeted region and avoid a lot of that high dose to really critical structures. And so that's why it's becoming, it's been something to be considered, it's being evaluated, and it's becoming much more popular. So it's something that I would definitely consider for somebody like this, if he has a good urinary function and his prostate isn't, like 300 cc's. I think that this would be very reasonable. I think that we're still have early data. I think it's a little bit too early to consider using it in high-risk patients. At least here at our institution, we don't offer it for high-risk disease. But for favorable and low-risk prostate cancer patients, we definitely are considering it, especially if they have really no urinary issues. They're not on anticoagulation for any other reasons. And I think it's a very reasonable thing. And we're going to be seeing more of it definitely in the prostate cancer world.
Great. So this is just a case variation. So going back, the patient had a multidisciplinary discussion, decided to go proceed with a RPLND, which is a radical prostatectomy lymph node dissection. So here's some videos showing what it looks like with the robotic prostatectomy. So this is actually the initial part of the surgery where the surgeon dissects out the urethra. This is an important component when the surgeon's able to actually dissect the neurovascular bundle and keep these structures intact. And here is just a photo showing the neurovascular bundle on the kind of walls of the prostate fossa that helps maintain erectile function, sensation. And then an important part of the surgery is the urethral reconstruction, and this is just showing how delicate this part of the operation is with robotic assistance. All right, and so the pathology shows, the final pathology shows a Gleason score 4+5. There's no lymph nodes involved, but there's extensive perineural and lymphovascular space invasion, which are poor prognostic signs or signs of recurrence. There was seminal vesicle invasion and extracapsular extensions, so the cancer actually extended outside the prostate capsule. And there's unfortunately a positive margin, and so presumably there's some microscopic disease. And so the post-op PSA, as low as it went, was 0.5 nanograms per milliliter. And the patient still remains incontinent, soaking pads kind of around the clock. So the next poll question, if it pops up here. Maybe we'll skip this one. Oh, there it is. Okay. So what is a prostate cancer specific PET tracer that can be helpful in patients with biochemical recurrence? Great. And Dr. Dess, would you want to comment on that question, how you utilize a PSMA PET or an Axumin PET?
Sure. We were fortunate enough to have sort of early access to a PSMA scan here. I would say Dr. Tendulkar and I have recently seen a similar patient, and not so, that could reflect some similar characteristics here, where we do a lot of PSMAs, more and more. And I think the world of genitourinary oncology in the intact setting and the post-op setting is kind of getting flipped on its head a little bit here. And it's a perfect example where we have technological advances and technological tools that sometimes outpace what we exactly know what to do with them. And so I guess we can separate a little bit what we would do with the imaging, which I think is the direct question here, and then how that dovetails with how we would manage this patient. If you look at the data at a PSA of 0.5 roughly, there's probably a 50% chance of seeing something that reflects where the majority of his cancer is. And I say the majority on purpose. It may not be all of his cancer, and it may not all be PSMA active or whatever radio tracer you use. And so that means there's open questions of what you do with people where you find something, and what do you do with people where you don't. And that's a 50-50 coin. So I think what what I love about my job, I think what we do is we just have to sort of counsel patients of, here's what we're doing. We think we can have a better idea of where your extent of disease is, maybe tailor our radiation plan to you. But we're living on the edge to know, what do we actually do with this information? And so if they tend to be negative in this specific situation, I'm largely managing this patient as if I didn't have the scan, and we can talk about that, and maybe we'll pass that to Dr. Tindalkar or Dr. Cameron. If it's positive, but the lymph nodes are in where I would be radiating anyway, maybe it's a modification of my existing plan. And if it's positive, but dramatically positive outside of where my radiation field was, and there's 10 different spots in the body, maybe I'm thinking twice about whether I'm radiating the pelvis. I'm going to pause here because there's a lot to unpack and I don't want to continue talking. I would like to hear what others have to say here.
Sure. I'm happy to jump in. So what's interesting with this patient's pathology is they turned out to have a higher grade cancer than what we knew initially. And so this reflects the fact that prostate biopsies are not perfect, and there's a lot of opportunities to maybe miss a high grade cancer. So maybe an MRI initially would have helped to see if there was something there. But nonetheless, this patient has some high risk features that are worrisome, that their cancer has not been sufficiently treated with surgery alone. So I totally agree that a PSMA PET scan would be great to rule out metastatic disease. When I counsel patients like this who have a PSA, 0.5 is around my threshold for ordering a PET, because as Dr. Des said, it's basically when you start to see at least a coin flip chance of finding a source of the PSA, at least grossly visible. So you can have one of three outcomes. You could have metastatic disease outside of the pelvis, in which case we're largely focusing on systemic therapy. It may be directed therapy to an oligo or a limited number of metastases, for example. Or they could have a PET avid disease within the pelvis, in which case we would typically do pelvic radiation and hormonal therapy. Or the PET scan may not show anything at all. And then we've got to make judgment calls about how aggressive we need to be with our treatments. Incontinence is common after prostatectomies. It can take patients up to a year or two before they can regain good bladder control. So in a patient like this, if they didn't have evidence of disease on a PET scan, I'd probably start them, and this is totally controversial, but I'd probably start them on hormonal therapy to buy some time to allow them to heal up, and then deliver radiotherapy later on once they feel like their healing has plateaued.
Yeah, I would agree with that, but I know we have to move on to the next case. I know we're running out of time, but yes, I would do similar. I agree with what Dr. Des and Dr. Tindalkar said so far.
Awesome. So we'll move on to the second case. We probably won't make the third, but it's good discussion. So this is a 52-year-old male. He presents to his primary care office with a couple months of kind of pinkening of his urine. They get a urinalysis that shows red blood cells, otherwise no whites or nitrates or leukoesterase, and the culture was negative. Standard referral was placed to urology for cystoscopy. He undergoes cystoscopy and subsequent CT urogram, which looks at kind of the lower urinary tract. It shows a 3-centimeter tumor on the left wall of the bladder with no impact on flow through the ureters, and otherwise staging was negative. This question I'll direct to Dr. Cameron. Why staging is important for bladder cancer, or T-stage, I guess specifically, and how does this guide your treatment option?
Yeah, sure. So yeah, this is very important to get the T stage, and that's actually why performing or knowing that your urologist who does the cystoscopy and performs the TURBT, which is where it's the transurethral section of bladder tumor, that they get down to the muscle, because basically we want to know if there's muscle present in the specimen, thus making it a T2 or beyond. And that beyond is often decided by the CT, CAP, and the other everything, the CT urogram, just the other mechanisms of staging. So really we want to know how deep that the tumor is, or how deep versus superficial. And this is important because it does guide treatment options. If it's a T1 or less, that's generally a urological issue. And so we would not be talking about radiation therapy in that regard. I mean, although that might be changing, but I'm not going to get into those details. But anyway, for T2 and for muscle invasive disease, that is where radiation therapy plays a big role. So I think it's really critical. And sometimes, when we get outside referrals and they have a biopsy from their cystoscopy of the bladder tumor, and where there's no evidence of muscle, because you really want to make sure that they get down to the muscle of the bladder, and you want to make sure that that muscle is indeed not involved. And so that sometimes we'll have our urologist actually repeat that type of biopsy to get down to the muscle, so we can confirm and be confident if either muscle is involved or if it's not, because it does change their management. When it's in the muscle, it's much more aggressive, so their management is much more aggressive.
So actually I have a video. Oh, shoot. The video didn't come through. So I apologize, but this is a video of a TURBT, basically using kind of a lasso tool to just scrape the tumor down and make sure they're through the muscle layer. So next poll question, what's the preferred treatment for muscle invasive bladder cancer after this procedure is performed?
Oh my goodness, this is a loaded question. While people are answering this, I was just going to add regarding the staging thing again for medical students. There's a difference between clinical staging and pathologic staging. So clinical staging is based on all of the clinical information that you have available at the time that you're seeing somebody. So radiographic imaging and cystoscopic imaging, things like that. And then pathologic staging is based on what is seen after the tumor has been surgically removed. So in this case, a radical cystectomy would give you pathologic staging. And oftentimes, bladder cancer is a great example of something where clinical understaging is common. In other words, somebody looks like they might have a T2 disease, which is invading into the muscle but not beyond, when in reality they might actually have a T3 cancer, which is extension beyond the wall of the bladder. And so understanding the difference between clinical staging and the pathologic staging is something that all of our trainees will learn very carefully.
And as a follow-up there, the students may not know Dr. Cameron is at one of the founding institutions of preserving your bladder. So take heed what she says very carefully. A lot of us have learned from their experiences in all seriousness. So we are lucky.
Admittedly, that's why I wrote the question, but well, we'll skip this question. And shoot, this video didn't come through either, but Dr. Tindalkar, would you, or Dr. Cameron, would you comment on what you contour and what dose you choose when you choose bladder preservation in this setting?
I'm going to defer to Dr. Cameron because I want to learn to see what the latest and greatest is at the Mecca.
That's also a loaded question, and it's actually evidenced by we've recently opened a very national trial for bladder sparing therapy, and it actually allows for everything. So you can really do anything. So because it's actually quite controversial. I think traditionally what we've done here in terms of contouring, so we often, we treat the whole bladder, we treat the bladder tumor, and we also treat the small pelvic. We call it the small pelvis, but it's basically the nearby pelvic lymph nodes. That's what we traditionally have done. But the UK actually often just treats just the bladder, and then there's also evidence where you could just treat the bladder tumor itself, where the tumor area was. And so it's very broad, and we don't actually have an answer as to which one is the correct way to do it. So I think that's actually why we're just opened. One of my colleagues is the PI of this very large national trial. We just opened this like a few months ago at this point in time, and it's going to be a very exciting trial, and it's actually adding immunotherapy and also sorts of cool stuff that's going to be done. But in order to really enable everyone to feel like they can put patients on it and feel comfortable, because there isn't a right answer about what we actually treat, it allows really for anything. So like I said, sometimes people will say, okay, I'll treat the whole bladder for a bit, and then I'll boost, meaning give a higher dose just to where the tumor was. Or some people, like we're of the mind of where we treat the small pelvis and then the bladder and then the tumor, but there really isn't a right way. And then same with the dose and fractionation. That's actually also controversial at this point in time. So traditionally, we would do like something like 64 and 2 gray per fraction, or 64.8 and 1.8 gray, and I could also get into the very original way of the Shipley way, which was the original way that he used to do treatment, and I was actually doing treatment twice daily with a break in between, and then considering it twice daily, or continuing it twice daily. But that we've largely moved away from that to the daily treatments. And then of course there's hypofractionation, which again means giving a higher dose per day, and that's actually out of the UK. So you could do 55 gray and 25 fractions. So where that trial allows for really anything except for with regards to fractionation, because we're adding on the immunotherapy, the data is still pretty early with regards to increased toxicity. Some like tiny trials. I mean, this is all really early data. There was like one tiny trial that showed that perhaps there was increased toxicity, GI toxicity, by doing the hypofractionation and adding on immunotherapy. But it's really hard to say, because then there was something else that came out that said it was fine. So we just said, all right, let's just make it simple and say for the fractionation, we'll keep it conventional, meaning 1.8 to 2 gray per day, and just try to at least keep that clean. But you can very reasonably hypofractionate bladder cancer too. So it is all over the place, and it really depends on what a physician is comfortable with.
Great. I will skip right to the end just because we're running out of time here. This is such great discussion. And I'll pass it to Dr. Khan.
That was wonderful, and I learned a lot. So just to highlight some other sessions that are coming together, there's oncology virtual series for medical students. The first one is on the 22nd. I believe that's next week. And then there's some in October and November as well. So sign up for that. That's also, I placed this on the RadOnc virtual website. Next slide. Thank you to our panelists. Thank you to Nav, who puts everything together. Make sure to fill out the post survey. Your odds of getting an Amazon gift card pretty high today, because we sent out 4 of those. Next slide. You can always contact us, and please utilize the website radoncvirtual.com. Next slide. That's the end, because we don't have any more for this year. We will be sending out an email, and we're just coming up with the sessions for the next year, and we're may have one in January. So keep your eyes peeled for that. Thank you to everyone.
Yeah, thanks, panelists. That was fun.
Thanks for having us.
Yeah, thank you so much.
Can I just also say thanks to Dr. Khan and Fields and the rest for organizing this? You guys filled a huge gap last year when COVID shut everything down, and a lot of medical students didn't have access to rotating and learning from those of us who get to work with students on a limited basis already. So kudos to you. Thank you for doing this, and I hope this continues to be a success in the future.